When immune system turns against the nervous system, the result can be rapid paralysis, sensory loss, or even respiratory failure. In such cases, therapeutic plasma exchange or TPE can be life-saving. Hi, and welcome to the Transfusion Vitals channel. So today we will explore the key neurological condition where TPE plays a vital role. Thus, TPE helps in neurology. Therapeutic plasma exchange removes the pathogenic autoantibodies, immune complexes, and complement components that attack the nervous system. Its rapid effects beneficial when quick immunomodulation is needed. It often used in acute flares or treatment-resistant autoimmune condition. So let's see all the condition one by one. ADEM or acute disseminated encephalomyopathy. It's a rare immune-mediated inflammatory disorder of CNS that often follow a viral illness or vaccination. Though corticosteroids are the first line of treatment in severe or steroid refractory cases, TPE can be vital escalation step. What is ADEM? It's a monophasic demyelinating disorder, mostly affect children and young adults, present with acute encephalopathy, motor weakness, ataxia, seizure, or visual loss. MRI shows multifocal white matter lesion, often bilateral and symmetric. Why use plasma exchange in ADM? So, it helps to remove the circulating autoantibodies and inflammatory mediators thought to cause demyelination. It provides immune modulation when steroids or IVIG fails. It can lead to rapid neurological improvement in some cases. So when we have to start the TPE, when there is failure to improve after high dose of IV methylprednisolone, there is severe presentation of coma, brainstem involvement, rapid deterioration, or there is refractory or fulminant ADM. According to the ASFA classification, it is classified as category 2. GBS or Guillain-Barré Syndrome. It is an acute immune-mediated polyneuropathy often triggered by infection that can progress rapidly to paralysis and respiratory failure. TPE is a proven first-line treatment that can significantly shorten disease duration and improves the outcome. What happened in GVS is that the immune system attacked the peripheral nerve myelin or axon. Patient develop progressive weakness, areflexia, sensory loss, and sometimes respiratory failure. It is often preceded by infections like Campylobacter jejuni (CMV) or EBV. This is according to ASFA guideline is category 1 and it is indicated as the primary treatment. The benefits of TPE that it accelerates motor recovery, decrease the ventilated time of the patient and it should be initiated within 7 days of disease onset. So more early initiation, better outcomes can be there. CIDP or chronic inflammatory demyelinating polyneuropathy. It is a progressive immune-mediated neuropathy that affects the peripheral nerves leading to weakness, numbness and functional disability. When corticosteroids and IVIG are insufficient or contraindicated, TPE offers a proven fast-acting treatment option. So CIDP is a chronic counterpart of GBS. It involves relapsing or progressive demyelination of motor and sensory nerve. Symptom involve symmetrical limb weakness, reduces reflexes, sensory loss, gait imbalance. So when we have to use the plasmapheresis in CIDP, when there is failure to respond to corticosteroids or IVIG, there is rapid worsening or severe disability and need for quick symptomatic relief prior to surgery or rehab initiation, or we can use as a maintenance therapy. So TPE, according to the ASFA guidelines, it's category 2 and there are various benefits of TPE in CIDP. So many patients have experienced rapid measurable motor involvement and improvement, especially helpful in functioning limiting. In CIDP, plasma exchange is not just a rescue tool, it is a powerful therapeutic bridge that helps the patient regain function while long-term therapies take effects. It's a rare progressive neurological disorder that primarily affects children and young adults, characterized by severe drug-resistant seizures, progressive hemiparesis, and cognitive decline. Although the exact cause remains unclear, autoimmunity is strongly suspected, making therapeutic plasma exchange a potential immunomodulatory option in selected cases. So, what is Rasmussen encephalitis? It's a chronic immune mediated progressive inflammation of one cerebral hemisphere. It typically presents with the focal seizure or epilepsia partialia continua (EPC), progressive hemiparesis, and cognitive deterioration. On MRI, there is progressive hemispheric atrophy. The role of plasma exchange is not yet clear, but there has shown some studies which states that there is a removal of circulating autoantibodies or T cell related cytokines that contribute to cortical inflammation. It acts as a immune modulating bridge in early or active disease. It may help in reducing seizure frequency, slowing neurological deterioration, delaying the need for the hemispherectomy. So in most cases, surgical treatment become inevitable for seizure control. Then the TPE become the main supportive or temporizing but not curative. The ASFA classification is not yet formally classified RE, and in this the plasma exchange may offer the temporary relief from the storm of inflammation. So a small window of hope in this disease that often progresses despite the best efforts. Lambert-Eaton syndrome. It's a rare autoimmune disorder of neuromuscular junction often associated with underlying malignancy, especially small cell lung carcinoma. While symptomatic therapies and immunosuppression are first line, therapeutic plasma exchange may be considered in specific cases. In Lambert-Eaton syndrome, it is caused by the autoantibodies against the presynaptic PQ type voltage gated calcium channel, also we called as VGCCC. This blocks the acetylcholine release at the neuromuscular junction, and it will lead to a classical triad of muscle weakness, hyporeflexia, autonomic dysfunction. According to the ASFA guideline, it is category 2, grade 2C. The role of TPE in this is it will remove these autoantibodies from the circulation and provides rapid short-term improvement in muscle strength. It is especially useful when rapid worsening of symptoms are there, preoperative stabilization need to be done. So it's a bridging to immunotherapy, and it can be used in severe paraneoplastic presentation. Myasthenia gravis. Myasthenia gravis is a chronic autoimmune disorder that targets the neuromuscular junction, leading to fluctuating muscle weakness and fatigability. In severe flares or crisis situations, therapeutic plasma exchange provide rapid relief by removing the antibodies that block communication between nerve and muscles. So the autoantibodies either against the acetylcholine receptor, which is most common, or against a muscle specific kinase, more severe involves the bulbar involvement, and less commonly it's seronegative or LRP4. The symptom which can be seen in the patients can be ptosis, diplopia, bulbar weakness, fatigable limb weakness, or in crisis we can see the respiratory failure. So the TPE, it will remove the pathogenic antibodies like acetylcholine antibodies or muscle specific kinase antibodies. It will reduce the immune complexes and complement, which provide the rapid symptom improvement in myasthenic crisis, preoperative optimization, and in severe or refractive myasthenia gravis. So, according to the ASFA classification, if there is myasthenic crisis, the ASFA category 1 is given, and in moderate to severe MG, the category 2 is given. So we can also use the IVIG in these type of patient. The onset of action for the plasma exchange is rapid, whereas for IVIG it is slower. It will take 3 to 5 days. Whereas if we talk about the efficacy is equal for both the treatment. but the plasma exchange is best for the muscle kinase antibodies, and IVIG is best for mild to moderate Myasthenia Gravis patient. So outcome we have already talked that it will cause a rapid improvement in muscle strength, respiration and swelling. So in Myasthenia Gravis, plasma exchange provide a lifeline, especially when there is a problem with breathing, swallowing or speaking. It is fast, effective and essential in the crisis care. Multiple sclerosis. It is chronic demyelinating disorder of central nervous system driven by autoimmune inflammation. While most relapses respond to steroid, a subset of patients experience severe steroid refractory attacks. In such cases, TPE can help reverse the neurologic deficits and prevent permanent damage. MS, it's a T cell and B cell mediated demyelinating disease characterized by relapsing, remitting, or progressive courses. Symptoms involves are optic neuritis, limb weakness, sensory loss, ataxia, bladder dysfunction. The first line of management in relapse cases is IV methylprednisolone. So when we can use the plasma exchange, so plasma exchange is especially helpful in steroid refractory relapses, fulminant demyelination, severe optic neuritis or transverse myelitis, as TPE removes the circulating autoantibodies, complement factors and pro-inflammatory cytokines. According to the ASFA category, the MS with steroid resistant exacerbation is categorized as 1, whereas categorized as 2 if there is acute attack and relapse, and in chronic it is categorized as 3. Despite these neurological disorder which we have discussed in this video, there are various other disorders where we can use the therapeutic plasma exchange, which includes your paraneoplastic neurological syndromes, paraneoplastic demyelinating neuropathies, Hashimoto encephalitis, stiff person syndrome, vasculitis, Wilson disease, and etc. In neuroimmunology, timing is critical. Therapeutic plasma exchange offer a rapid, effective way to reverse immune attacks when every hour counts. Subscribe to Transfusion Vital for more episodes on life-saving intervention in transfusion and apheresis medicine.